carry on dengan psikoterapi.
Can you see my slide?
Yes, Nadia.
Okay. For today's seminar, our group 4 will present on a seminar entitled Psychotherapy. Okay. What is psychotherapy? So psychotherapy, it is a form of therapy to treat psychological problem between therapist and patient, either verbally or non-verbal. And it works by developing a trusting relationship between the patient and also the psychotherapist. So psychotherapy, it helps patients to ventilate their predicament and frustration, accept their strong and weak points, recognize their feeling and ways of thinking, and also help patients to cope with life difficulties. So for our seminar, we will cover some types of psychotherapy, which are the cognitive behavioral therapy, and etc. So for my part, I'll present on cognitive behavioral therapy and behavioral therapy, while the other topic will be presented by the other presenter. Okay. So for cognitive behavioral therapy, so it is a short-term structured therapy involving active collaboration between the patient and therapist. So this cognitive behavioral therapy is developed by a psychotherapist, Aaron Berg, based on his cognitive theory of depression. So based on this cognitive theory of depression, there is three components, which is the first one is the cognitive bias or distortion. So Aaron Berg, he proposed that a depressed pupil are more likely to focus on the negative aspect of a situation while ignoring the positive. For example, a patient, he had failed one test, and therefore he think that he will going to fail for all of his exams. So he is more likely to focus on the negative aspect while he ignore the positive one, which he can succeed if he work work harder. And then the second
So,
component is
sekejap
negative.
saya celah-celah.
Okay, doktor.
So the first, so when we talk about cognitive behavioral therapy, we need to understand the underlying principle behind it. So principle behind it, when we ask principle behind it, these two are the principles behind it. One is cognitive distortion, second is negative self schema. So cognitive distortion ni bahasa mudah dia in simple term is what we think or the way we think will determine the way we feel. Itu dia punya simple term dia. Okay. So two people can experience similar things, but because they think differently, these two people will have different emotion. Faham? Contoh, uh, dua beradik, two siblings, mother pass away. So one thinks that I no longer have anybody um, to support me. So dia akan rasa apa?
Hmm.
What emotions that will come up from that?
Sad.
Sad. Okay. The other one would think, now my mother is no longer here. That means I am now responsible for my family. So the feeling, the emotion,
Determine.
so whatever that is lah, determine ke apa ke. So maksudnya, apa yang differentiate one becoming so depressed, berguling-guling, merata-rata, wailing, in sadness, but the other one move on with life. So the back theory says that because the way they think, the way they view the problems different, therefore the outcomes is different. So itu first theory. So faham konsep ni, you boleh explain it in your own words. You don't have to remember that small tiny box there. Just faham konsep. Okay, second one.
Okay, the second one is the negative self schema. So, it is the idea about self and the world which developed during childhood and may come from negative experiences. So, example of experience that might contribute to negative schema such as parental criticism, neglect or abuse, or bullying at school. So, basically, it's the bad experience, patient experience.
Eh, uh, negative self schema ni is not just about that. Negative self schema ni yang tiga benda tu, cognitive triad tu. Apa benda tu?
Uh, Sebelah doktor.
Ha.
So this negative self schema, it will let the patient to develop cognitive triad in which the patient will have negative view about the world, negative view about the self, and also negative view about the future.
Okay. So basically bahasa mudahnya, cognitive triad ni adalah once you have one form of schema, one way of thinking, dia akan uh, dia akan berjangkit dekat benda-benda lain. It will infect other parts. Once you feel sad about one thing, you will also feel sad about other things as well. For example, you kena marah dengan you punya lecturer, so you start fikir pasal diri you, I am useless. And then minggu depan you ada exam, then you start relate, that means because I'm useless, I will fail that exam. And because of that, you tengok keliling, kawan-kawan semua boleh buat, tak boleh buat, maknanya they are all against me. They are not in support of me. And so itu maksudnya you start off with one feelings, dia akan berjangkit dekat other things because these three things ni is interrelated. Who you are as a person will determine how do you see the world and the future. Okay. Kenapa? Apa kena mengenai CBT with all of this?
Because CBT aim to examine, validate, and restructure the patient maladaptive cognitive automatic belief.
Okay. So what we've talked so far ni adalah the 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 formation of maladaptive pattern of thinking yang menyebabkan dia depressed. So CBT is about rewiring that whole maladaptive pattern, restructuring that whole pattern. So that's why it takes a therapy with multiple sessions and a structured way. So that's what CBT is all about. Okay, carry on.
Okay. So CBT previously it is mainly for treatment of depression, but currently it is extensively used in treating panic disorder, obsessive compulsive disorder, personality disorder, as well as anxiety disorder. Okay, and then the goal of the therapy, it aims to facilitate remission and to prevent or reduce recurrence by helping patient to identify and test negative cognition. It also aims to develop alternative and more flexible schema to the patient and to rehearse both new cognitive and behavioral response. So by changing the way a person thinks, it can alleviate the psychiatric disorder of the patient. Okay, and then strategies and technique of the CBT. So the duration of treatment could be up to months or years, and usually it will be conducted in 12 to 24 sessions, once a week for 45 minutes to 1 hour. So the session is divided into three phases. The first phase is the history taking and psychoeducation, which about 4 to 8 sessions. The second phase is the cognitive restructuring, about 4 to 8 sessions. And the third phase is the maintenance and preventing relapse, 4 to 8 sessions, or it might take over years. So this is the most important phase of the treatment. Okay, so for the component of the cognitive behavioral therapy, there is three components. The first one is the didactic aspect or the psychoeducation, followed by the cognitive techniques and behavioral technique. So for the didactic aspect or the psychoeducation, as Doctor has explained previously, so it is an um, to intervention with systematic structure and didactic knowledge for an illness and its treatment to enable patient to cope with the illness. So during
Nadia, do you have example? Do you have in your slides anywhere examples of cognitive distortions?
mm, no, doctor.
Okay. So first part ni is about identifying patients punya problem so that you know what you need to work on when you come to the stage of cognitive and behavioural. So in order untuk tahu what's wrong with the patient, you need to know different types of cognitive distortions. Okay, so balik nanti baca pasal cognitive distortion or cognitive errors. Just type aja, you will find banyak je example. Some dekat YouTube pun ada yang very good animation lah. Lepas tu ada pictures, di Google Image pun nanti you come across a lot. So dia akan give different example. All you need to know adalah remember one or two examples and relate it with common clinical cases. For example, cognitive errors yang common adalah magnifying ataupun magnification. Maksudnya, contoh, ada somebody yang contoh yang lebih mudah sikit lah, overgeneralizing. Contohnya, dia fail one subject. And then sebab dia ada cognitive error jenis generalizing, dia tend to generalize. Maksudnya, semua benda aku fail, semua benda aku tak boleh buat. Tak ada benda satu benda pun dalam hidup aku ni yang berjaya. Padahal sebenarnya ada je. Masa tadika dia boleh baca, IPSR dia dapatlah 2A, masa PT3 adalah 3A. Ada je masa-masa yang dia okey. Tapi because of one particular event dia fail, dia generalize that means everything else in life ni is a failure. So cognitive error yang dia ada adalah generalization. Okay. Ataupun another common example adalah jumping to conclusion. Jumping to conclusion contohnya lecturer tu cakap awak ni tu pun tak tahu. Antidepressant pun tak tahu contoh. Dia terus jumping to conclusion, maknanya aku fail lah posting ni. Cara Dr. Nizam cakap tu memang maksudnya memang gaya-gaya aku ni gaya fail posting. Alright, so that's also apa kita panggil cognitive error yang akan create what feeling? Dia akan create negative feeling lah kan. Kan tadi kan teori asal dia adalah what you think will determine what you feel. Okay, so what we think ni ada pattern je. Another example adalah catastrophizing. Catastrophizing tu maksudnya macam catastrophizing ni melebih-lebih. Contohnya lecturer kata macam awak ni tu pun tak tahu. And then dia pun kata aku dah lecturer menghina aku, lecturer rasa aku ni memang tak boleh buat, lecturer tu cakap aku ni macam budak yang patutnya campak bawah jambatan je, kecil-kecil kenapa aku tak mati. Maksudnya dia catastrophize dia punya problem. A common example catastrophizing ni adalah patient yang ada panic attack. Okay? And so contohnya dia jatuh laju. Dia terus catastrophize dalam kepala dia. Ini mungkin tanda-tanda ya Allah, aku dah amal tak cukup lagi ya Allah, aku insurans baru ambil 2 bulan ni, tak masuk lagi dalam polisi ni, tak cover premium lagi ni. Dia dah start fikir-fikir dia dah start fikir yang jauh-jauh lah. So that's catastrophizing. Okay? So this is what we do during the first part of CBT. That is kita nak analyze, kita nak tahu. Macam mana kita nak tahu? Guna apa? Guna apa? Kerak limau tengok dalam air. Kita buat apa? Kita guna apa? Guna history taking lah. Kita buat apa kawan sikit. Takkan nak guna brain scan. Takkan nak buat lambar panca. Through history lah. Kan? Maknanya contohnya bila patient cakap dia ada depression. Okay, can you tell me what's going through your mind? How do you feel? Why do you feel such way? What makes you think? What come across in your mind? And what we trying to do adalah kita nak identify dia punya pattern of thinking. Alright, so if you see somebody yang depressed, you talk to them. Sometimes even with cross-sectional assessment tu, you dah boleh dapat agak-agak jenis yang macam ni. Another example is patient yang perfectionist. Dia ada black and white thinking. Black and white thinking maksudnya either you success or you fail. There's nothing in between. And contohnya mesti distinction. Tak distinction maknanya loser. And so that is perfectionist punya cognitive error. That's what leads them to depress. Okay, carry on.
Okay. So, and then the second part of the CBT is the cognitive technique, in which from this technique, the therapist will elicit the automatic thought of the patient, testing the patient automatic thought, identifying the maladaptive assumption, and test the validity of the maladaptive assumption of the patient. Okay, so for the step, the first one, the therapist will elicit the automatic thought of the patient. So automatic thought, also known as cognitive distortion or cognition, that intervene between external event and a personal emotional reaction to the event. So the therapist try to elicit what the patient cognitive distortion. So for example, a patient might feel that if a friend pass by and does not acknowledge me, it means the person is disrespectful towards me. So
Kenapa dia
this
panggil? Why do we call it automatic thoughts?
uh, cognitive distortion of the patient. Oh, no.
We call it automatic thoughts because it almost comes automatically. Where maksudnya mesti dia akan terfikir macam tu. Maksudnya you don't have to force him to think so. Macam kalau you ada kawan kan, you ada kawan yang jenis memang negatif. Memang negatif. Tak boleh lah, tak pandai lah, aku tak ni. So it's almost macam automatic come to them. You don't have to ni. Ataupun you ada kawan yang memang jenis beria yang macam yang positif belajar semua kan. Semua benda dia oh tak apa, kita boleh. So it's almost automatic. So a lot of thoughts pattern ni sebenarnya dia, dia suits personality orang. Dia bukan something yang dia buat-buat. Dia suit that characteristic. So somebody yang depressed, contohnya dia ada underlying borderline personality disorder. So borderline personality disorder ni dia ada specific pattern of thoughts. And pattern of thoughts ni dia develop over time, tapi once dia stable, dia almost macam automatically. Contohlah, kalau you orang yang ada low self esteem kan, low self esteem, dia akan ada kecenderungan untuk nampak sisi yang negatif. Macam kan you all biasa dengar glass half empty, half full kan. So kalau orang tu to begin with ada low self esteem, so thoughts dia is very likely untuk have tendency towards yang kenapa lah tak boleh, macam kenapa orang lain boleh, tak boleh, dia always ada cenderung macam tu. So it's the same as opposite lah. Alright, so carry on, sambung. So the first part ni kita nak elicit, kita nak identify apa dia punya automatic thoughts. Then next.
Okay, the second part is testing the automatic thought. So the goal is to encourage patient to reject the inaccurate automatic thought. So it's done by generating other possible alternative reason for the situation, such as the therapist say that probably the person was in hurry or probably he was preoccupied with his own problem. So at this stage, we try to encourage patient to reject the automatic thought by giving possible reason for the situation.
Okay, now we don't give them reason. Okay, itu yang bezakan psychotherapy dengan counselling. So in counselling, kita bagi tahu dia, janganlah fikir macam tu, awak ni okey je, dulu kan awak pas je. So that's counselling. Okay, tapi in psychotherapy, kita nak empower them to come up with their own thoughts. Kita nak teach them the skills to alter their own thoughts. Okay, so sebab tu dia nanti later you akan tunjuk contoh testing automatic thoughts. Okay, that's what you think, but can you think of any other possible of explanation why he was in a hurry? Why he wasn't acknowledging you. So maknanya kita encourage dia. So that is therapy. And so psychotherapy ni sepatutnya patient yang cakap lebih banyak daripada terapis. So kalau terapis lagi banyak cakap daripada patient, so that is counselling. Awak jangan cakap dengan counselor macam ni, nanti dia terasa hati. Tapi maksudnya saya nak kata different modalities, which is reasonable lah. Sebab patients yang jumpa counselor ni, they're not depressed. Dia stress, dia tak boleh nak cope. So we're talking about different approach for different people. Okay, coming back, going forward.
Okay, and then the third component is to identify the maladaptive assumption of the patient. So So we try to know what the patient think about the automatic talk. So patient might say that if the pupil don't respect him, I am not a respected person or I am not a good person. So these such rules inevitably lead to disappointment and failure and ultimately to depression for the patient. Okay. And then the fourth component is to test validity or of maladaptive assumption. So the therapist asks patient to defend the validity of their assumption. So the patient may state that they should always work up to their potential, and a therapist may ask why is that so important to you.
Okay,
Okay.
Dana?
Okay, and then after the cognitive technique, so it should go together with behavioral technique. It used to help patient to understand the inaccuracy of the cognitive assumption and learn new strategy and ways of dealing with the issue. So it involves changing the behavior of patient to reduce dysfunction and to improve quality of life. So the example of behavioral technique that can be used is first the scheduling activity. So it is an hourly basis. So patient keep record of the activity and review them with the therapist. And then graded task assignment. The therapist break tasks into subtasks so that the patient can succeed the task. So it will allow mini accomplishment of the task. And then cognitive rehearsal. The patients imagine and rehearse the various steps in meeting and mastering a challenge. Self-reliance training. It trains patients to do simple things on their own. And then role playing is a particularly powerful and useful technique to elicit automatic thought and to learn new behavior. Okay, so
Now, behavioral component of CBT ni, dia punya teori dia sebenarnya adopted from cognitive theory of depression. So cognitive theory of depression kata apa? The way you think will determine your mood. So behavioral theory dia adalah what you do will also determine your mood. Okay, for example, you're feeling sad. As a result of feeling sad, you refuse to go out to see your friend. Okay, so that's your behavior. So apa outcome of that behavior? When you don't go out and see your friend, what will happen? Will you be feeling happy?
no.
You become even more sad because kesadar. You become even more sad because orang lain semua happy, orang lain semua pergi makan, aku duduk sini mereput. Lepas tu you become more sad. Bila you become more sad, you become more withdrawn. Bila you become more withdrawn, you become even more sad ke sadder kot lah. So maksudnya the cycles tu continue. And so the behavioral component tu is basically about breaking the cycle with changing the behavior. So cognitive component nak change apa?
The patient talk.
Nak change maladaptive pattern of thoughts. So the behavior therapy nak change maladaptive pattern of behavior. Okay, so another common example is patient ada social phobia yang menyebabkan dia takut untuk present. Bila dia takut untuk present, lagi dia jadi takut, betul tak? Bila you tak pernah present, you akan jadi lebih insecure, duduk kat belakang, duduk kat belakang, duduk kat belakang kan? Tapi what you can do is break the cycle. Start presenting. Start present depan seorang, start present depan orang, start present depan 3 orang. So breaking the cycle will eventually make the anxiety to disappear. So that is actually an example of behavioral modification, behavioral therapy. Okay.
Okay. So now we go to behavioral therapy. So behavioral therapy involves changing the behavior of patient to reduce dysfunction and to improve their quality of life. And this behavioral therapy focuses on the removal of undesired symptoms without addressing the inner psychological conflict. So for the behavioral therapy, there is some types of behavioral therapy, and I'll discuss on the systemic desensitization, therapeutic graded response, flooding, as well as exposure and response prevention. So for systemic desensitization, it is based on the behavioral principle of counter conditioning, whereby a person overcomes maladaptive anxiety by approaching the feared situation gradually. So indication of systemic desensitization, it is clearly identifiable for clearly identifiable anxiety provoking stimulus, phobia, obsession, and also compulsion. So this systemic desensitization has three phases. The first one is the relaxation training. So by relaxation, it will produce a physiological effect opposite to those of anxiety, such as low heart rate, increased peripheral blood flow, and also neuromuscular stability. So relaxation training can be done by such as yoga, hypnosis, tape recorded exercise, as well as mental imagery. After that, um, is the stage of hierarchy construction, in which patient is asked to create a hierarchy list of 10 to 12 scenes in order of increasing anxiety. From the list event that cause anxiety to the most event that trigger anxiety. After that, we go into the desensitization of the stimulus phase. It will proceed systematically based on the hierarchy list while patient in deeply relaxed state. Okay.
Apa
So
maksud counter conditioning? Saya mention dekat situ counter conditioning. Counter conditioning is basically what we do in in systematic desensitization lah. Counter conditioning tu apa?
sorry, I'm not sure.
Tulis dekat situ. Conditioning tu maksudnya apa? Siapa boleh tolong? Siapa ingat yang ni topik apa Topik learning theories year 1.
Is facing the fears.
Conditioning means you associated one thing with another thing. For example, uh, you you have experience of being bitten by a cat. Okay? And that's terrifying for you. Contohnya masa you kecil. So therefore you associate that cat with that painful experience. So you start to associate. Now, yang gigit you only that one particular cat. Tapi because you already conditioned that thought, every single cat in this world you associate dengan horrifying experience. So therefore you develop cat phobia. So that is what it meant by association. Now association ni can be that can occur in so many things. Contohnya you ada contohnya if you can come across orang yang ada fetishism, kan, dia conditionkan certain objects dengan sexual connotation. Ada orang dia conditionkan, contoh dia ada PTSD and dia drive, dia accident. So dia start condition yang driving ni is scary thing. So that's all of those are conditioning process yang occur a lot in anxiety. Contohnya you pernah present once, you kena humiliated dekat depan sebab you lupa zip seluar ke whatever. So you had a very bad experience. So ever since then you associate presentation as something yang awful. Okay, so counter conditioning ni apa?
Opposite of the condition.
So counter conditioning ni is dissociating those two. Dan sebab tu dia bagi contohnya you couplekan dia dengan relaxation untuk reduce untuk change your schema in your brain that driving is going to end up dengan accident, kucing you end up kena gigit. Okay, faham? So that is what dia punya underlying theory. So you will see that in phobia, obsession, compulsions. And so in OCD for example, dia condition. And setiap kali dia salam orang, dia mesti wash hand. Dia dah condition those two. So we want to dissociate that you can salam orang without having to wash hand every single time. Tapi sekarang kenalah wash hand. Maksudnya ni dulu lah. Okay, sambung.
Okay, and then the component is the therapeutic graded response. It similar to systemic desensitization, except realization technique is not involved and the treatment is usually carried out in a real life context. So exposure is graded according to hierarchy, but there is no realization. So for example, patients afraid of cats and might progress from looking at a picture of a cat to holding the real one. Okay. And then the other component is flooding. It's similar to graded exposure, but there is no hierarchy. So in flooding, there is no hierarchy, no realization. So in this type of therapy, the clinician will encourage patient to confront fear situation directly without a gradual build-up. So this method many patients refuse because of the psychological discomfort involved. And this therapy is contraindicated when intense anxiety would be hazardous. For example, in patient that has heart disease or fragile psychological adaptation.
Okay, so contoh flooding ni, so contohnya kalau somebody yang takut kucing tadi kan, so you started dengan gradual exposure, you tunjuk gambar kucing, you suruh dia pegang gambar kucing, you do it slowly. Flooding ni, you masukkan dia dalam bilik, you letak 20 ekor kucing dalam tu. Apa yang kita nak achieve? We don't do this, tapi maknanya this is literally, we don't normally do flooding anymore lah. Apa yang kita nak achieve? Dia kan, dia punya konsep dia sama macam you ada kawan yang takut gila roller coaster. Okay? Flooding ni macam Faris pegang tangan dia sebelah, Afif pegang tangan dia sebelah, you pun restrain dia, you pun letak dia dalam roller coaster, you pun let go roller coaster tu on, you pun apa yang you nak achieve? Selain you nak buat hendak kat dia lah, apa yang you nak achieve? Therapeutically apa yang nak achieve?
Rapid desensitization.
Basically, you nak face the fear. So that they know apa yang dia fear most tu does not happen. Contohnya lah, orang takut kucing ni, sampai dia ingat kalau kucing tu duduk dekat dengan dia akan mati. Faham tak? Some people ada that kan, aku akan meninggal dunia kalau kucing ni duduk dekat dengan aku. Ataupun kalau dia naik roller coaster tu, mesti dia akan mati. So bila dia buat, tak mati lah, best pula. So yang tu kita panggil instant therapeutic effect lah. Tapi in psychiatry kita tak buat lah. Sebabnya tak ada kerja lah pula kita nak bawa patient naik roller coaster. Tapi that is the theory. So another example is kawan you takut sangat nak present, takut nak present semua tu, you terus suruh dia present depan conference dekat OCD. So that is flooding lah. Tapi provided that dia tak mati lah. kalau dia dapat heart attack betul-betul dan dah mati, then susah pula cerita. Doesn't work lah. Okay, sambung.
Okay, and then the last therapy is the exposure and response prevention. So this therapy is mainly for used for OCD. It to weaken the link between obsession and compassion. So the therapist will provoke a person not to engage in their behavioural ritual and compassion. And from this therapy, it will teach the patient how to tolerate distress without engaging in their behavioural ritual. And slowly, patient will learn to resist compassion to perform ritual and eventually stop engaging in this behaviour.
Okay, habis.
That's all.
Okay, alright. Now, untuk exam purposes, you kena tahu ni je. You kena tahu satu is dia punya clinical application. And contohnya macam in exam you dapat kes OCD. Dan kita tanya nak, can you give example of psychological intervention that can be used in this case. So you kena come out lah dengan yang ada tadi tu. Ataupun the other way around, you mention patient ada depression. And then you want to give patient ni CBT, and then we may ask, okay, in what other conditions CBT might be useful other than depression. Maknanya you kena tahu dia punya dia punya indication dia. Yang kedua adalah you need to understand uh, what's behind it and roughly how it's done. Enough in order for you to explain sahaja. Mana we don't really want you macam contoh Nadia tadi duk cerita pasal stages semua kan. You don't have to remember the stages. It's good that she share that untuk kita faham. And tapi CBT enough untuk you, enough contohnya kalau in exam kita tanya okay, what do you want to do with this question? I want to give CBT for this question. Okay, can you explain how would CBT help in this question? And so you can answer something like, so CBT is useful in patient who has cognitive distortion. So we can use CBT to challenge the cognitive errors and provide more healthier alternative pattern of thinking in order to relieve patients from symptoms such as depressed mood, hopeless. And then further kita mungkin tanya, can you give example cognitive distortion that you identify in this patient? So contoh patient tu panic disorder. So it's classical. And so you can give example of cognitive distortion is catastrophizing, in which patient believe that every time he has palpitation, that means he will pass away. So level tu pun cukup dah. Okay, ataupun another example is patient ada social anxiety disorder, patient ada social phobia. And so you give example, we can do CBT. Okay, so can you give example of behavioural therapy that can improve patient's social behaviour? And so you boleh kata we can do role play during the therapy session, so get the patient to talk to us so that they boleh practice overcoming his fear in a experimental environment so that he can apply that in his real life. Okay, so basically tu je, level tu je kita nak you faham. And you can only do that if you understand. Jangan hafal tapi understand. So challenge that, always practice macam you want to use this untuk this, go back to the theory untuk check betul ke tak. Then you should be able untuk relate and understand example that lagi. Okay, now we may stop at CBT dengan behavioural therapy. Kita sambung ada terapi dekat some other slots in future. Ada apa nak tanya tak at this stage pasal psychotherapy?
Doktor,
Yeah.
saya just nak clarify balik yang tadi pasal, saya tak faham sangat lah pasal yang testing automatic thought tu kan. Maksudnya kita nak test patient tu punya thought, tapi maksudnya kita suruh patient yang come out dengan dia punya idea sendiri
Basically kita
macam ni kita nak.
Maksudnya instead of dia terus accept dia punya thoughts, kita nak dia challenge dia punya thoughts. Contohnya dia kena marah, dia terus fikir maknanya mak saya tak sayang saya. Dia terus terima that statement yang menyebabkan dia rasa depressed and later on suicidal ke self-harm. Okay, so what we want to teach them adalah do not simply agree with your thoughts. The thoughts are there, but you decide what thoughts you want to follow. So that's what testing the thoughts. Maksudnya kita challenge the thought. And sebab macam saya sebut dengan your friends the other day, our thoughts do not define us. Thoughts yang kita ada ni adalah benda yang datang dan pergi. Okay, so thoughts ni dia macam weather. Kan, maknanya hari ni panas, besok hujan, besok tu. Maksudnya dia berubah-ubah. So hari ni kalau kita depressed, hari ni kita sad, that does not make us a loser, a hopeless person, a worthless person. It just mean that today I am sad. Itu je. Tapi for somebody who is depressed, dia punya thoughts dia tu akan evolve into belief. Itu yang sampai satu tahap ada orang sampai delusion. Delusion rasa macam dunia ni akan kiamat sebab dia dah, the thoughts tu dah very heavy. Kalau you all ada belajar psychopathology kan? You all ada belajar delusion kan? You all ada belajar ideas of reference. Pernah dengar ideas of reference? Or overvalued ideas? Ada belajar tak? Ada belajar tak apa beza overvalued ideas dengan delusion?
Tak tahu
You
doktor.
all ada kelas psychopathology kan? Masa year 4 lah kan? Okay. You all tahu tak delusion tu apa? Apa delusion, Hasan?
Oh.
Delusion ada. Delusion is fixed false
Ah.
belief that is contradict to patient's background, social or functioning, and also it is
Okay.
okay.
Good.
Right.
Okay, so it's a false fixed belief. False fixed belief, unshaken despite contrary evidence, and it is not in keeping with patient's social or cultural background. Lebih kurang lah macam you punya wording tu. Dia punya highlight dia adalah delusion ni dia fixed. Now, fixation in delusion tu dia doesn't occur overnight. Okay, dia biasanya occur over periods of time. So before dia jadi fixed, kita panggil dia ideas of reference, or some in other situation kita panggil overvalued ideas. Contoh, orang yang ada persecutory delusion, dia believe 100% without any questions that jiran dia nak ambil harta dia dan nak keluarga dia mati. So that is persecutory delusion. Tapi before they come to that, dia akan develop dulu initially masa prodromal period, masa early stage of illness tu, apa yang kita panggil sebagai ideas of reference. Ideas of reference ni contohnya macam, pelik lah jiran aku ni. Bila aku parking kat sini, dia mesti dia parking kat sini juga. Dia mesti ada benda yang dia tak puas hati dengan aku. Dia mesti ada benda. So, dia start ada this ideas of reference. Ideas of reference ni maksudnya, dia rasa macam benda tu macam memang target dia. Contoh ideas of reference ni adalah contohnya kalau saya bagi contoh lah. Contoh Afif dia minat dekat seorang, Afif tak kahwin lagi kan? Tak kahwin lagi kan? Okay. So Afif minat dekat seorang. Dia minat dekat siapa-siapa, dia minat dekat Syazwani ke siapa-siapa, Afifah ke siapa-siapa. Lepas tu, disebabkan feeling dia tu, contoh, saya bagi contoh lah. Syazwani senyum dekat semua orang. Happynya aku hari ni dapat jawab soalan Rozanizam. Tapi Afif rasa, dia senyum dekat aku lah. So itu contoh ideas of reference. Okay, contoh je ni. Awak jangan pula ni tak tidur malam pula habis saya bagi contoh. So dia start jadi ideas reference. Okay, so ataupun overvalued ideas. So yang ni biasa kita jumpa dekat patient yang manic. Contohnya orang macam, baguslah kau. Dia start rasa macam, tengok orang menghargai aku punya kelebihan sebenarnya. Later on dia jadi grandiose delusion. Okay, apa saya nak cakap tadi? Kenapa saya cakap pasal ni? Saya nak cakap pasal that's how ideas develop. So orang yang depressed ke, orang yang anxiety ke, dia pun sama juga. Dia start dengan dia ada this idea and then dia agreeing to this idea sampai akhirnya idea tu jadi skema dia. Contoh orang yang depressed, dia ada this skema yang I am a loser. I'm worthless, I'm useless, I don't belong here. Okay, I am not going to be able to succeed. And so semua tu dia develop over time. And so one of the reason why it develop adalah bila dia just agreeing to dia punya, just sekadar bersetuju dengan dia punya thoughts. Tanpa dia questions dia punya thoughts. And sebab tu sometimes one of the good, kita panggil apa, good coping mechanism adalah self-talk. You tahu tak self-talk? Self-talk kan? Kalau orang main sport kan dia self-talk kan, dia kata sebelum dia nak berlari dia cakap kat dia, kau boleh buat, kau boleh buat kan. It's basically externalizing your own thoughts so that you don't fall into the belief that bila kau mesti kalah lah ni, makan angin lah ni, makan asap lah ni, semua tu. Tapi you do self-talk untuk encounter that. And cumanya self-talk ni tak samalah dengan hallucinatory behavior because you're not responding to internal stimuli. Okay, alright. So that's what we do in psychotherapy. Now, you all are supposed to ada sessions dengan psychologist untuk observe apa semua tu, tapi psikologis kita cuti bersalin, so you might not get experience untuk betul-betul jumpa atau tengok psychotherapy session, tapi at least you dapat some idea, and you boleh tengok lah Google, YouTube, ada je certain psychotherapy tu yang dia tunjuk contoh dia dekat tu. Nanti saya forward link dia dekat group saya, you all boleh tengok lah just untuk get some ideas lah. You see one, you understand the concept tu, you will be able to remember, because kita bukan nak suruh you perform pun, kita nak you faham je the concept dia. Okay, now what I need to do adalah, so that to make things easier for the next session, kita akan maybe cover ni masa case presentation next dengan saya, ataupun masa community psychiatry lah. Kita curi-curi saya punya some other slot lah. What we need to do adalah, so your friends yang dah prepare the slides ni, for the rest of the slides ni, please share it with your friends, so you all read it out, so that when they present next time, kita just discuss the essence of it sajalah. Maknanya you already read about it, kita just nak discuss. Maybe nanti saya tunjuk contoh modul CBT tu, so you all dapat idea apa example, apa yang dibuat dalam sesi 1 buat apa, sesi 2 buat apa, sesi 3 buat apa, so that you understand what's going on during the therapy session. Okay, any questions? Any burning questions or anything yang you want to clarify? So far, some of you have already gone to HTAA, some remains in IUMMC. So hopefully, you make full use of your presence there lah, to plug patient semua. You have case, you have you have on calls as well, and so find time untuk plug patient, see patient. Awal-awal ni tak ada masalah lah kalau you pun sama-sama macam patient loose juga, sama-sama clueless juga, tak tahu nak tanya apa, tak apa. Just talk to the patient, get to know, belajar sikit-sikit. The more you do, the better you get. Tapi baca lah, of course balik baca lah. Contohnya plug patient psychotic, tak tahu nak tanya apa, balik baca, and then next day ataupun next time plug lagi another patient psychotic, so that you know. Patient psychiatry ni ada dua jenis, ada two types. Okay, one is where they can give a very good history, but they don't have any acute symptoms. So this is good for your long case. Alright. The second type of patient yang cannot give any history, tapi has all of the acute symptoms. Contohnya patient yang acute psychotic, ada loosening of association, ada flight of ideas, ada pressured speech, ada flat affect, whatnot. So they cannot give you history, tapi they can give you some symptoms. So this kind of patient good for your short case. Now your exam would be somewhere in between. So patient yang ada a bit of both, can give history and at least ada some symptoms. So any types of patient that you see, it will benefit you in some ways. Whether you can appreciate the benefit or not, to the result. Okay, so just bila pergi ward tu, just watch out je lah, yeah. Jangan pergi sorang-sorang, jangan club patient sorang-sorang. Make sure you have company, and then watch out for your boundary with patient. Jangan duduk dekat sangat, and then respect patients. Jangan jangan intrude patients, jangan make them uncomfortable, jangan record, jangan share things outside, respect their confidentiality. So all of that, if you do that, inshallah you can make full use of your presence there, inshallah. Okay, tak ada apa nak tanya?
Doctor, I have one question. Let's say in the clinic, the patient has suicidal thoughts and still insists to do suicidal attempt, and then how we want to manage the patient, because in IMC there is no psychiatric ward.
Okay, so kalau in IUMMC, what we do is we'll send patient to emergency, and then patient will be sent to HTA from emergency to be admitted to HTA. Okay, and cuma admission to psychiatry ni dia ada dua jenis. One is voluntary, another one is involuntary. So this is where it's a bit tricky, and because we cannot detain patient involuntarily. Contohnya patient suicidal, we think patient will benefit from admission, and tapi you cannot detain patient at IIMC. Okay, and because it is not a gazetted area for admissions, involuntary admission. So what we do so far adalah kita get family members to accompany, so the family is responsible for patient's care, or kalau kita tak dapat, then we may need to use security untuk escort patient, and then patients transferred ambulance to hospital via ambulance. The tricky part is, what if patient refuse and abscond ke atau gone missing ke, ini yang tricky part yang kita IMC ni still tak ada backup lah. Tapi selalunya patients yang datang akan ada dia punya ada seperti contohnya kalau kita ada students yang suicidal, and the next person yang kena accompany adalah fellow mahalah. And so we'll contact fellow mahalah, and atau in some cases supervisor, and I have cases where lecturers yang accompany students as well untuk just standby lah. Tapi if the risk is high, nak tak nak memang kena admit. We have admitted students from UIA Kuantan pun to Dahlia Ward before, because kalau dia warrant admission untuk dia punya risk, then paksa lah.
Okay, thank you, Doktor.
Kalau you all clerk patient, and then patient tu bagi tahu you patient tu suicidal, apa you kena buat?
Kena bagi tahu MO.
Okay, betul. Memanglah in real life you will do suicide assessment, that person blah 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 blah, itu in exam. Tapi in real life, you cannot manage this patient because you are not the treating doctor. You just there lalu lalang, boleh tak saya nak interview, tu je. Okay, so what you need to do adalah you need to inform the treating doctor. Doktor, tadi saya clerk patient ni bagi tahu dia suicidal. What if the patient said to you that jangan bagi tahu doktor saya suicidal? Don't tell the doctor that I told you that I'm suicidal.
Kena bagi tahu juga.
Yes, you are obliged to tell juga, and you kena bagi tahu, minta maaf, and I have duties of care untuk inform, because whatever happened to you, I don't want to be responsible. And somebody must be able to help you. So it's important for me to tell. So hopefully not to that stage lah, tak adalah sampai tu. Tapi what I'm saying sebenarnya there's a rule, kita panggil Tarasov rule. Tarasov rule is basically making compulsory for doctors untuk inform patients yang ada risk in the situation where informing other people tu akan reduce the risk. Contohnya dia bagi you patient ni student, dia bagi tahu kalau hantar saya balik asrama, saya akan terjun daripada tangki air sekolah contohnya. Tapi jangan bagi tahu mak saya. No, there's no such thing as patient's autonomy in this case. You still have to break the confidentiality. All you need to tell is the apa kita panggil, dia punya rules je lah. Dia punya rules. Dia sama je juga macam contohnya patient tu ada HIV. Dia kata saya tak nak bagi tahu wife saya. So tak boleh. You still kena bagi tahu. I need to notify. Because this is the rules. Government punya rules adalah semua infectious disease yang dalam kategori ini kita kena notify. So sama juga dengan suicide. It falls under the same principles as well. Okay, alright. Tak apa, just experience it. Any problem masa bedside teaching ke apa tu, you can ask any lecturer so that you can learn more from real things. Okay, thank you so much all. See you next apa ya? Jumaat ni, case presentation
Ya, Doktor.
Siapa yang ni dah ada case dah ke?
Dah.
Siapa?
Nama patient ke?
Ah.
Rozanizam.
Apa?
Bruce Minding.
Bukan under UIA doktor.
SNKKM. Information cukup ke tak? Information tu boleh bagi history, personal history semua ke? Boleh?
Boleh?
Okay, tak apalah. As long as patient boleh bagi history cukup untuk you present, maknanya dia ingat kerja kat mana dulu, sekolah kat mana, apa semua tu ada past history tu okey lah. Alright, thank you. See you Friday.
Doktor, Jumaat ni online ke face to face?
Dr. Ali cakap apa? First presentation?
Depends on doktor kot.
Tapi kalau face to face, tak boleh buat dekat IMM, silakan. Sebab you all tak boleh duduk satu tempat yang sama. Takkan nak buat tengah padang. Buat dekat, do you all prefer face to face ke online?
Kena tanya group. Kena tanya the rest of them.
Orang okey je mana-mana doktor. Kalau face to face kadang-kadang kita orang boleh buat dekat com.
Cuma com, kalau you all duduk jarak-jarak macam tu, tak ada mikrofon, setting juga. Tak apalah. You all decide lah. Nanti bagi tahu saya. Okay, thank you. Assalamualaikum.
Salam.
Thank you doktor.